Good afternoon. Thank you for joining today's webinar on opioid addiction screening and assessment for people in the criminal justice system. My name is Allison Upton. I'm a Senior Policy Analyst at the Council of State Governments Justice Center, and I will be moderating today's webinar, which is hosted by the National Reentry Resource Center. To give you an overview of today's webinar, first we'll do introduction of our panelists, and then we will provide an overview of the Bureau of Justice Assistance and the Council of State Governments Justice Center. Then we will hear from Dr. Roger Peters from the University of South Florida, who will present on screening and assessment options and considerations for opioid addiction. We will also hear from Jack Charlier and Phillip Barbour from the Center for Health and Justice at TASC, which is Treatment Alternatives for Safer Communities. They will discuss the development and use of the Texas Christian University Drug Screen Opioid Supplement. At the end of the webinar, we'll have time for questions and answers. And so I'd like to introduce our panelists now. To begin with, we'll hear from Bethea, who is the Policy Advisor for Corrections at the U.S. Department of Justice's Bureau of Justice Assistance. Previously, Andre served as the Director for Program Operations and Policy at the New York City Department of Correction, where he managed external relationships with community-based organizations and research institutions, as well as developed policy and curriculum, identified best practices, and supervised programmatic initiatives for adolescents and young adults in custody. Andre's career in criminal justice began as an analyst for the New York City Police Department, but he also previously worked as a legal coordinator and provided law library and research services for people in custody at the New York City Department of Correction. He has a bachelor's degree in criminal justice from John Jay College of Criminal Justice and a master's degree in library and information science from Pratt Institute. Our second speaker will be Dr. Roger Peters, who is a professor in the Department of Mental Health Law and Policy at the Louis de la Parte Florida Mental Health Institute at the University of South Florida, or USF, where he has served as a faculty member since 1986 and as department chair from 2004 to 2011. He also holds a joint appointment in USF's College of Public Health. Dr. Peters received his PhD in clinical psychology from the Florida State University and is a licensed psychologist in Florida. He is the lead author of the monograph, Screening and Assessment of Co-Occurring Disorders in the Justice System, which was published by SAMHSA in 2016. Dr. Peters is a faculty member of the National Judicial College and serves on the Florida Supreme Court's Task Force for Mental Health and Substance Abuse Issues in the Courts. He is a recipient of multiple Fulbright scholarships, serving in Ghana in 2015 and Paraguay in 2017. Our next speaker will be Mr. Phillip Barbour, who is a master trainer at the Center for Health and Justice at TASC. Mr. Barbour has worked in the field of substance abuse counseling since 1990. He joined TASC in 1991 and has worked in a number of the agency's criminal justice programs, including several years as an administrator with TASC's corrections transition programs. Barbour joined the Residential Substance Abuse Treatment Training and Technical Assistance, or RSAT, faculty in August of 2010. He previously served as Staff Development and Training Coordinator for TASC, and in that role provided training for TASC's 350-plus statewide staff. He is also a registered trainer with the Great Lakes Addiction Technology Transfer Center, which is part of a national network of centers sponsored by the Federal Center for Substance Abuse Treatment. Barbour's expertise is shaped not only by his professional experiences, but also by the fact that he once came through the treatment and criminal justice systems, which he now helps to improve. Our fourth speaker will be Mr. Jack Charlier, who leads criminal justice consulting and training services for the Center for Health and Justice at TASC. He specializes in criminal justice policy and civic engagement, including developing strategies and solutions that lie at the intersection of criminal justice, behavioral health, and community. Prior to joining TASC, Charlier spent 16 years of service in the State Parole Division of the Illinois Department of Corrections. As Deputy Chief of the Northern Region, he led system-wide parole operations for the Chicago metropolitan area. He also served as the Criminal Justice Representative for the Institutional Review Board at the University of Illinois Chicago and is an adjunct faculty member at several Chicago area universities, where he teaches criminal justice courses around ethics, leadership, research, and management. He received his Master's in Public Administration from the Ohio State University and his bachelor's degree in mathematics at the University of Illinois, Urbana. So I want to say thank you for all of our presenters today for joining the webinar. So just a couple of housekeeping items for the audience before we move forward. Just as a reminder, anytime during the webinar you can ask a question by typing it into the Q&A panel on the bottom right-hand portion of your screen. This includes both technical and content-related questions. We'll try to reply to technical questions in the chat window as we go. For the content-related questions, we're going to be keeping a running list, and we'll address them all at the end of the webinar. We'll do our best to get through as many questions as possible. If you encounter any technical or audio problems during this webinar, please call WebEx Technical Support at 1-866-229-3239, 866-229-3239. Please understand that there are some technical issues that you may not be able to resolve, and for this reason we are recording the webinar, and we will post it on our website at csgjusticecenter.org/NRRC. We should have the webinar posted online by the end of next week. And now I will turn things over to Andre Bethea to talk a bit about the Bureau of Justice Assistance. Andre?
Thanks, Allison, and good afternoon, everyone. My name is Andre Bethea, and I am the Policy Advisor for Corrections here at the Bureau of Justice Assistance, which is within the Office of Justice Programs inside of the U.S. Department of Justice. So you'll hear BJA for the most part. I am also the Policy Advisor that oversees the Second Chance Act Reentry, improving reentry for adults with co-occurring substance abuse and mental illness here in the Policy Office. At BJA, our mission is to provide leadership and services and grants administration and criminal justice policy development to states, local, and tribal jurisdictions. Specifically, BJA provides funding to support law enforcement, combat violent and drug-related crime, and combat victimization. Through the development and implementation of policy, services, and sound grants management, BJA strengthens the nation's criminal justice system and restores security in communities. I will now turn things back over to Allison to continue with the rest of this particular webinar.
Thank you, Andre. I'm going to just give some brief background now on the Council of State Governments Justice Center and the National Reentry Resource Center, or NRRC for short. So the Justice Center is a national, nonprofit, nonpartisan organization that serves policymakers at the local, state, and federal levels from all branches of government. Staff here provides practical, nonpartisan advice and evidence-based, consensus-driven strategies to increase public safety and strengthen communities. On this next slide are some examples of publications released out of our office, including on the topics of justice reinvestment, reentry and employment, and adults with behavioral health needs under correctional supervision. The Justice Center operates the NRRC in partnership with the Bureau of Justice Assistance, and since 2009, the NRRC has provided technical assistance to more than 600 grantees. The NRRC also serves as a source for user-friendly interactive information on best practices in reentry. We're always adding new content to our website, and we send out a monthly newsletter that provides information about the latest research, funding opportunities, webinars, and other news about reentry. So we encourage you to sign up for the NRRC newsletter and other newsletters, and to do so, please visit the link on your screen that we're going to be posting at the end of today's webinar. Okay, now we're going to shift into the main portion of our presentation today. So I will turn it over to Dr. Roger Peters to discuss screening and assessment of people with opioid addiction. Dr. Peters?
Thanks very much, Allison. It's good to be here today, and welcome everyone to the webinar. Here are just some introductory points about what we're going to be covering today during the webinar. Go ahead and move the slide. So here are just a couple of the outline points. We'll be looking at some clinical considerations to start out with, just practical considerations in screening and assessing for opioid addiction. We'll certainly look at independent screening approaches and some instruments that you can consider for opioid addiction, and we'll be looking in more detail, obviously, at the Texas Christian University Drug Screen 5 with the opioid supplement later with our other presenters in the webinar. Finally, we'll look at some assessment approaches, techniques, some practical tips, and also some instruments for use with those having opioid use disorders. So let's go right into the content. I think we all understand the great crisis we're in terms of the opioid use epidemic and the high prevalence rates of these disorders. The recent estimates as of 2016 are over 2 million people in the U.S. have an opioid use disorder, and of course that number's increased since that point. We know that these individuals are oftentimes very difficult to engage in treatment. Dropout rates are higher for this population. The motivation levels are lower typically. Actually, only about 1 out of 5 individuals with an opioid use disorder is actually in treatment at any given time. With these disorders come the elevated risk for overdose and mortality, and of course we see that in the headlines and the TV news briefs that we see almost daily in many of our states, and some states of course are affected more than others by that. We also have high rates of co-occurring mental disorders among this population, particularly in the justice system, will be one of the featured populations we're talking about today in the webinar. The estimates are that about over 40% of individuals with opioid use disorders have at least one co-occurring mental disorder. And we'll talk during the program today about some strategies for screening and assessing for co-occurring mental disorders. Finally, when we use specialized assessment approaches, we're certainly going to obtain better outcomes for offenders and for our general clients in our programs. We have more effective engagement by the intake counselors, but also we're able to triage people to specialized services more quickly, including detox, MAT, medication-assisted treatment, and intensive psychosocial treatment that go hand in hand. So what are some key characteristics and features of opioid addiction that we need to take into consideration that have implications for screening and assessment of offenders in our system? First off, drug use, as I think is commonly known, is accustomed our offenders to instant gratification. So what are the implications here? So if you're waiting during intake at a program for an assessment while you're experiencing negative emotions such as anxiety or fear, this can be a really difficult process. And we have to recognize that, acknowledge that it's a difficult process, check in with our offenders or clients periodically, clarify the schedule of what's going to happen next, and perhaps optimally have other clients or recovery specialists, for example, talking with individuals who are waiting for the assessment process to assure them that we have a program for them that's going to help them with to address their needs, and that we understand what their current condition is. So part of the difficulty in engaging people, of course, in this process who have opioid use disorders is the fear of withdrawal and getting clean. And this is particularly true of people with opioid disorders versus other types of drug use, cocaine or methamphetamine, other types of drugs. And so not only do we have the physical pain related to withdrawal, the body aches, tremors, cramping, diarrhea, other symptoms, but just the fears of getting clean and monitoring that goes with that. We can reduce some of these fears of the withdrawal process and the pain that goes with that by discussing the detox protocols, of course, in our programs, sharing information for those who have chronic pain disorders, for example, of over-the-counter medication that may help them deal with these chronic pain conditions in a more effective way. So the bottom line is that we have individuals who are waiting for assessment or engaged in the assessment process who are agitated, demanding, verbally abusive to staff, and it's very common to have grievances filed against staff at this point, for example, and certainly staff need training in knowledge about the residual behavioral consequences of withdrawal syndrome, such as agitation. These individuals may have experienced frequent prior episodes of treatment. However, they may have cycled rapidly through treatment, and it may have been ineffective. And so we have to deal with some of the pessimism also of people entering treatment who have not successfully maintained abstinence or graduated from treatment programs in the past. So another issue clinically is that we have to counteract distrust at intake. I think this is pretty common among people with opioid use disorders. Often this is driven by shame and the distrust that other people will judge them, belief that they'll judge them, and that they're going to be stigmatized. I think our response is that we want to thank people for returning to treatment rather than and we certainly would want to see them in treatment many times rather than not see them at all in treatment, or to have them overdose or possibly die as a result of overdosing. So we also need to be sharing the information that we're not judging individuals coming in, offenders coming into our programs. We're here to help. We'll talk about that more later on. So really a welcoming environment as people enter the assessment process, enter the programs. Pain management issues, certainly pain from withdrawal that we talked about earlier that has to be dealt with, and our offenders need to be educated about what that process is. There's pain medication that's been used in the past, certainly, that we have to deal with as part of the addiction process. We certainly have to also prepare our offenders for medication-assisted treatment. So what medications will they receive? When will they receive the medications? And we do this at the time of admission about the approach to withdrawal, the use of medications in MAT. We also provide ongoing education within the programs. For example, nurses may provide education about MAT during community meetings if you're in a residential or a secure setting, for example. Again, the high rates of co-occurring disorders we talked about before. Over 40% of the population affected by that. So we really have to have programs for opioid use disorders that are really dual disorder programs, co-occurring programs. Most of the individuals in our programs who have opioid use disorders are going to require more intensive levels of treatment, right? So not good candidates for regular outpatient treatment 2 to 3 times a week. These are individuals who are going to need intensive outpatient treatment or residential treatment typically for opioid use disorders. One other consideration I'll share with you, it's not on the slide, but be careful about eligibility exclusions for individuals with opioid use disorders that are based on violence or aggressive behavior. This certainly may prevent individuals from receiving follow-up services, and I'm not suggesting that this shouldn't be considered, and certainly there are cases where there's public safety risk that these individuals can't be accepted into programs. But I think we need to realize that our offenders are often agitated because they're not getting medications. Also, part of the withdrawal syndrome is agitation, and that individuals may also have co-occurring mental disorders that may contribute to the aggressive behavior, agitation. So individuals may be agitated without posing a threat to others. We need to understand the context of the aggressive behavior and not simply exclude people based on a prior history of violence or aggressive behavior or some signs of outward agitation in the program. So be careful about that as well. Co-occurring mental disorders. I won't spend a lot of time about this. We've mentioned this already. Many clients have co-occurring mental disorders. Sometimes offenders in our programs get the runaround about mental health issues when they're enrolled in drug treatment for the first time or the second time. We need to engage them in a discussion about the dual disorders and their mental health problems, have them discuss this, and for us to be open to discuss and engage them in what needs to happen in terms of treatment. Now, of course, the mental disorders, the symptoms of those disorders may be induced by drug use. So depression, anxiety, agitation, as we mentioned, may all be symptoms of drug use. And so part of the challenge of the assessment process is to figure out which is which, and if there's a bona fide mental disorder, which of course you can only determine over a period of time after somebody's detoxed and they're abstinent. So we want to provide screening for major mental disorders and for suicide risk, and certainly people are going to have a higher rate of both suicide behavior and major mental disorders in these treatment settings. We talked about agitation behavioral problems during the withdrawal process are common, and our staff need to be trained in these issues. Certainly, we need to be prepared to refer individuals for a more formal psychological psychiatric evaluation, both for medication consultation, but also for diagnosis and effective specialized treatment for co-occurring disorders. What are the major types of screening that we need to provide in our settings? In addition to screening for co-occurring mental disorders, here are the main areas that I recommend that we provide a universal screening for every single offender coming into our programs at intake for screening and assessment. So high rates of all of these disorders. We'll briefly discuss some of the screening instruments that are available for each of these disorders in the next few slides. So here is the monograph that Allison mentioned that came out published by SAMHSA 2016 that has a whole range of instruments, screening instruments, assessment instruments, and information about how you obtain those, both instruments in the public domain and those that are proprietary or available at cost. So this is available free of charge as a monograph on the SAMHSA website. I'll move on to the next set of slides, really talk about screening instruments for these different types of disorders. And we start with substance use disorders. So here are a range of public domain instruments, and there are many, as you're aware of, and many more that are not on this slide, of course. But these are some sample instruments that are, as it turns out, these are public domain instruments free of charge, all available over the internet, by the way. The TCUDS-5 that you see in the right-hand corner is one that's going to be described in a lot more detail by the presenters as we look at the opioid supplement for that particular screen. And here is some of the information from that supplement that describes a little bit about the specific elements of the opioid supplement for the Texas Christian University Drug Screen 5, which is really, I think it's the most commonly used screen for substance abuse now in the criminal justice system in the United States. Dr. Kevin Knight at Texas Christian University developed this, and it mirrors the DSM-5 and will be discussed in more detail. Again, it's available on the Texas Christian University Institute of Behavioral Research website online. So, mental health disorders. What about screening instruments for mental disorders? Again, I'm recommending that we provide a universal screen for our offenders who have opioid use disorders for mental disorders as well. And here are some available public domain instruments that are commonly used in the justice system. All have good psychometric properties of reliability and validity. These take 5 to 8 minutes to administer, and they're free of charge to use. All available on the internet, again, by the way. Let's move on. So, well, the serious disorders that we're looking for in those mental health screens are these disorders, and we'll look at trauma disorders in just a minute in more detail. I won't go into detail about these because, but these are the major disorders that typically can disrupt and impair functioning in substance abuse programs for our offender populations. What about screening for trauma and post-traumatic stress disorder, PTSD? I'm recommending, again, because of the high prevalence rates of these disorders, that we provide a universal screen for all of our offenders. It doesn't have to be provided by a licensed clinician, but certainly the referral for treatment and additional intensive services would need to be provided by licensed clinicians. There certainly are a lot of screens available. We'll get into that in just a minute. I'll share with you some examples of these. But again, positive screens for PTSD, post-traumatic stress disorder, and trauma should be followed up by a more comprehensive assessment by a trained clinician. Some of the issues I think that are relevant here is that PTSD and trauma are oftentimes neglected in a formal assessment or in the screening process. And as a result, the symptoms of these disorders can be misattributed to low motivation, depression, hostility, anxiety disorders, and individuals, as a result, don't get the appropriate specialized treatment that they need for these co-occurring disorders. So here are some of the instruments that are used to screen and assess and diagnose for trauma disorders, including post-traumatic stress disorder. I won't spend a lot of time on these, but again, most of these are public domain instruments. There are screens listed here that look at different life events that have contributed to post-traumatic stress disorder. And there are also screens here in the lower right corner, including the PTSD checklist for DSM-5, the PCL-5, which is probably the most commonly used screen for PTSD in the U.S., developed by the VA system, but applicable to many populations, including criminal justice populations. And again, like the TCUDS-5 that you'll hear more about today, the PTSD checklist for DSM-5, of course, mirrors the diagnostic criteria for post-traumatic stress disorder and provides a diagnostic impression. There are other instruments listed here that are used for diagnosis of post-traumatic stress disorder. And these are described in a lot more detail in the monograph that published by SAMHSA that was described in the previous slides. Other screening targets are certainly other areas for screening and assessment. We want to look at withdrawal severity. We'll look at some specific instruments in just a minute for opioid use disorder withdrawal and alcohol withdrawal as well, alcohol use disorder withdrawal. We want to look at eligibility for medication-assisted treatment. We'll also look at this in a minute. Transportation is a huge issue for engaging people in opioid use disorder treatment. People that live in rural areas particularly have difficulty in engaging in treatment. If you're involved in MAT, methadone, for example, you're going to be receiving daily doses or frequent doses. And so transportation is critical to have people stay engaged in MAT. So we need for, there's certainly a need for arranging bus passes. If people are on Medicaid, it's possible in some states to get support for transportation. Housing, also a very significant barrier to opioid use disorder treatment. We certainly need sober living apartments and halfway houses for our offender populations that are involved with opioid. Other major medical problems, certainly we need a medical workup for all individuals being screened in our programs. HIV, hepatitis C are major issues, other types of chronic health disorders as well. And then attitude towards treatment. What is the previous treatment history? What have been your experiences in treatment? What has led you to drop out of treatment in the past? What are things that you'd like to work for in treatment presently? So all key issues. We talked about screening for withdrawal severity for both opioids and for alcohol use disorders, and I won't spend a lot of time on this, but these instruments are public domain, available online, and they help us to understand the estimated opiate tolerance level of individuals coming into our programs. Also help us to guide the dosage range for withdrawal induction using methadone, Suboxone, Vivitrol. So I won't go into detail about these instruments, but just for example, the Clinical Opioid Withdrawal Scale, COWS, is the acronym, reviews 11 signs and symptoms of opiate withdrawal and yields a score from 0 to 36, indicating mild, moderate, or severe withdrawal. So again, there's some instruments out there that help us in our assessment process for opioid use disorders. So what about screening for medication-assisted treatment eligibility? I will point you to a lot more comprehensive document that goes into detail about these issues, and that is the SAMHSA Treatment Improvement Protocol, or TIP, number 63, TIP number 63 by SAMHSA, which is Medications for Opioid Use Disorder, and that is published in 2018. I would highly recommend that you take a look at that and looking at MAT considerations, including eligibility. This TIP was chaired by Dr. Robert Schwartz and includes sections on screening and assessment of opioid use disorders, exactly what we're talking about today. So I won't go into detail on all of the elements here, but we want to look at the period of recent abstinence. For example, for use of naltrexone, Vivitrol, we need 14 days of abstinence before we can start that protocol. And here are some of the other areas that are, of course, very important to assess. Other issues not on this slide: medical history, substance use history, treatment history, of course, and then history of Subutex, Suboxone use. Drug testing, very important in the process of screening and assessment, of course. Providing a baseline of substance use helps to confirm the client history that's been provided during screening and assessment of recent substance use, and of course helpful in diagnosing substance use disorders and the severity of the disorders. It's clearly helpful to have rapid results from these tests for people who are coming into our programs, who are screening and we're trying to figure out what's going on, people that may be involved with polydrug use, and some of the drugs that have high overdose potential, we need to make sure that we're testing for, including fentanyl. Oftentimes our panels don't include some of these highly addictive, highly toxic substances that can lead to overdose, and this can be have severe adverse consequences, clearly. So the positive test for opioids, again, should trigger screening for withdrawal and use of medication-assisted treatment for this population. I won't go into detail, but I mentioned one of the universal screens really that we recommend is screening for criminal risk, and this means risk for arrest. And so I won't go into the detail. There's trainings that involve a full day of training just on this topic area, but again, I think many of your programs out there are already using a formal risk screen and a risk assessment approach. There are many instruments out there, and I have a few examples in the slides. These instruments look at both static factors that don't change, such as criminal history, but also dynamic or changeable factors that become the targets of our treatment plans, our case plans, and that are incorporated along with medication-assisted treatment, other psychosocial interventions to address the important areas of need for our offender populations. And here are the factors, the dynamic risk factors that are included in these risk assessment instruments, risk screens and assessments. Post-traumatic stress disorder, not yet verified, but there's some indication that that may be an independent risk factor for arrest that needs to be included in risk assessment for offender populations. Here are some examples of the instruments. And again, we don't have time to really spend a lot of time going over these, but there are many evidence-based instruments out there that should be incorporated in the screening process that we provide for offenders who have opioid use disorders. So what about intake assessment strategies for looking at assessment, the more comprehensive assessment approach for opioid use disorders in our offender populations? Just some quick considerations to start out with. We want to have a welcoming, non-judgmental approach. Some of you may be familiar with the NIATEC approaches, providing a comfortable reception waiting area, explaining what's going to happen to offenders, to clients in the programs, meeting one-on-one with an intake counselor to discuss what's going to happen. We also need to normalize the symptoms that go along with withdrawal for people with severe opioid use disorders, that clients are experiencing a lot of physical pain. And again, if we can use recovery support specialists, people with lived experience going through opioid use disorders, other addictive disorders, this can be really, really helpful during the intake process, establishing trust, ability to relate to persons who have a history of these disorders and the situations, knowledge of the situations that they're going through, including withdrawal, enhancing motivation for treatment and recovery, and talking about risk reduction alternatives also with the client population. Some programs have specialized opioid intervention staff that are trained and conduct all the intakes with individuals who have opioid use disorders and may be flagged as having high needs. We also provide education about MAT and other services during the process. We mentioned this before. One thing that's really interesting that's important is that particularly for programs that are shorter term, we need to begin the transition planning process at the intake stage, starting very early and including recognition of the different treatment options and facilities that are available out there, including private pay, insurance, programs that take insurance, private insurance, or public sector programs as well. But that process needs to start very quickly, and oftentimes we don't have a lot of time to engage people and to plan for that transition to, if someone's leaving a detox facility, for example, there's not going to be a lot of time to transition. In some cases, we may want to delay the assessment process if people are intoxicated at the time of admission to intake. And so it may be that we need to detox first before we conduct a full assessment. Usually there'd be a 1 to 2 day waiting period. At the upper end, there'd be a 5-day period where we'd be reasonably assured that all major drugs are cleared out of the system. So we may delay conducting the assessment, also depending on the extent of collateral information that we have at the time. We want to check on the consistency of information provided to intake staff and medical staff at different points in the process during intake that will help us determine if we're getting valid and reliable information. There are some specific assessment instruments that we could recommend that are evidence-based. The Addiction Severity Index is probably the most commonly used psychosocial assessment instrument for addictions. The Global Appraisal of Individual Needs, the GAIN instrument, is a proprietary instrument, and there's a couple versions of this that are used in the assessment process, and they're listed here. We won't go into detail on those. There are also a number of instruments available at the same website that has the screening instrument, the TCUDS-5, that has a number of different options for assessment instruments. So I'd encourage you to take a look at those as well. Certainly the ASAM, American Society of Addiction Medicine, has a set of criteria for evaluating need for treatment and placement in treatment. And there is an ASAM assessment instrument that's available that looks at different dimensions of opioid use and other types of addictive disorders. These are the dimensions that are incorporated into that instrument, into that assessment process, that lead to a triage process into different levels of care. And that really is what this assessment's all about, is determining level of care based on the needs of a particular client in one of the dimensions that's included in the assessment instrument. So the ASAM instrument is now used widely, I think, in the United States for individuals with opioid use disorders to place in specific levels of care. There are instruments also for assessing co-occurring disorders, and these are a range of instruments that are commonly used. Some are objective measures. Others are structured instruments, such as the SCID-5, listed on the right side, which provides a diagnosis for drug disorders, and some specific instruments on the left-hand side, one, for example, that looks specifically at co-occurring disorders. So just to wrap up, got a couple of things I wanted to share with you about targeted areas for assessment. We talked about withdrawal severity, discussed this previously. There are some formal screens available to look at severity of withdrawal from opioids or alcohol. Drug interactions are very important to look at as well. For example, if somebody's on a MAT regimen, medication-assisted treatment, using benzodiazepines can be very toxic. So staff training is very helpful here, becoming comfortable and asking about all type of medications and drugs that the offender is using. It may be that the person asking these questions at intake is not knowledgeable about the specific interaction effects, but the individual can find out and also refer the offender to medical staff to provide that information and to help out in addressing drug interactions. Overdose history is a clear part of the assessment process for individuals with opioid use disorders. We talked about mental disorders already and medical disorders, prior injuries and use of pain medication. So again, many pain management clients, of course, have injuries that then lead to use of pain medication, and these individuals oftentimes become addicted. Then they have difficulty obtaining ongoing supplies of prescription medication and oftentimes turn to street drugs as a result of that. So we need to evaluate that process and how that's evolved over time. What about risk-taking behavior as well, sharing needles, risky sexual behavior that co-occurs with substance use? Also looking at periods of abstinence. What's the longest period of time that the offender has stayed clean in the past? What was going on in that particular situation that we can learn from? What about criminal justice system involvement? Clearly, we need to ask about if the person's on probation or parole. This can be a source of support for funding for treatment, right? Also, if they're involved in a drug court or a mental health court, this could be a source of support for residential or intensive outpatient treatment as well. Are there pending charges that the individual has hanging over them that may affect their involvement in the treatment process? If they're involved in the child welfare system, also this may be a source of funding support for the for opioid use disorder treatment, and also a source of leverage and potential motivation for treatment of individuals that we're seeing at the point of intake. Functional aspects of use. How did people start using? When did they use? What was the first age of use of the opioids and other drugs? Why did they start using? What's supporting their opioid use at this point? How are they supporting their use? Are they stealing? Are they engaged in prostitution, day labor? All important areas. Certainly the support network, including the family supports, other social supports, family history of use, current environmental conditions that may lead to relapse, including family members using drugs and alcohol. Then importantly, we need to not forget about personal strengths and skills. And this includes non-traditional areas. So what has the offender done in the past to stay clean? Even if they've been in jail or prison, drugs are available, right? And so they've done something to abstain during those periods, if in fact they have been abstinent. Resourcefulness. So even people who have an active drug habit, they've survived on the street. So in a way, you can turn this and look at a strength of how individuals have been able to survive on their own. If they're in treatment even involuntarily, they're still showing up, and we need to reinforce that they're making effort even if they're court mandated to be in treatment. Asking about difficult things that they have encountered in their life and overcome, things that they didn't think that they could make through the process. So this is a way of addressing some of the maladaptive thinking, such as I can't do it. I can't make it through opioid use disorder treatment. It's impossible for me to get clean again. And again, the level of care required, for example, by using the ASAM instrument and process. So wrapping up, I know there's been a lot of information in a short amount of time, but I hope it's been useful. We have high rates of these addictive disorders, of opioid use disorders. Co-occurring mental disorders are very common. The good news is we have a wide variety of screening and assessment instruments that are available. Many of them are free of charge, non-proprietary instruments. And these include screens for opioid use withdrawal. And so I encourage you to use some of these specialized approaches and instruments for your populations. There are certainly a lot of implications for staff training in signs and symptoms of withdrawal, of treatment for this set of disorders, of medication-assisted treatment, and the whole range of intensive treatment, both MAT and psychosocial treatments for this population. So thanks very much. I'm going to stop there and turn it back over to our staff at this point. Thank you.
Thank you very much, Dr. Peters, for your presentation. Very great content so far. We appreciate it. And just quickly, before I turn it on to our next presenters, I just want to remind the audience that anytime during the webinar, you can ask a question by typing it into the Q&A panel that should be down in the bottom right-hand corner of your screen. And we are tallying all the questions, and we're going to have a portion at the end sometime to get through them. So with that, I will now turn it over to Phil Barbour and then Jack Charlier at TASC to discuss the use and development of the Texas Christian University Drug Screen Opioid Addendum in more detail. All right, Phil, I'll turn it over to you.
Thank you so much, Allison, and welcome everyone. I'm glad everyone was able to join in. So Dr. Peters had alluded to the Texas Christian University Drug Screen 5 a number of times during his presentation. And I wanted to go into a little bit more detail about that, but also to talk about a opioid supplement that the Center for Health and Justice at TASC helped create with TCU along with Dr. Kevin Knight and Dr. Patrick Flynn. So I'm going to go ahead and make sure I got my slides up here. There we go. So as you can see in this slide, the TCUDS, as we affectionately call it, it's an updated version of the TCU Drug Screen 2, which has been out in the field for nearly 20 years. It's based on the most recent Diagnostic and Statistical Manual Information, or DSM-5. The TCU Drug Screen 5 screens for mild to severe substance use disorders, and it's particularly useful when determining placement and a level of care in a very quick way. This was the opioid supplement. It was a collaboration between us here at the Center for Health and Justice at TASC, along with TCU, Dr. Knight, and Dr. Patrick Flynn. So to give you a little bit more of a detailed version of this, there's a rule to remember when using the TCUD-5 that would trigger the need or the use of the opioid supplement. So I'm going to show you what those 3 questions look like here in just a minute. When and how to use the opioid supplement? Well, you have to use the TCUD-5 first. There are some questions built into the TCUD-5 that if the response to the TCU Drug Screen 5, which is on page 2, questions 13E, 13F, and 13R, and these are questions specifically regarding opioid use. If the response to those 3 questions is anything more than never, then that would trigger a flag to go ahead and use the opioid supplement. A couple of notes, clinical notes about how the TCUD-5 works. And this has often confused those who maybe work in secure locations such as jails and prisons. When you do the questions on both the opioid supplement and the TCUD-5, you're looking at the last 12 months prior to any controlled environment. And what that looks like on the ground, if you have an individual maybe who's been in lockup for the past 4 months, and you ask him when's the last time you used, he's thinking, well, it was, before I got arrested 4 months ago. That would be correct. But if he answers, well, I haven't used in 4 or 5 months, which would include the time he's been incarcerated, that's not the approach you want to take with administering this tool. So again, another rule of this is the last 12 months prior to any controlled environment. That would include jail, prison, perhaps a treatment program where they don't have ready access to substances. Also, the test itself, the TCUDS, has 17 basic questions, which are some are yes or no responses, and then some are rated on a scale from never to daily. So again, just to kind of advance that and give you a look at what this portion of that TCUDS looks like, I've highlighted the 3 questions that I just referenced, but as you can see from looking at the way these questions are asked, they walk you through a number of substances, everything from alcohol all the way down to prescription medications, including opioid pain relievers. And again, those 3 questions that are specific to opioids I've highlighted here, and as you can see, the responses to the right would be anything like never, only a few times, 2 or 3 times a month, 1 to 3 times per week, or daily. So again, the rule of thumb is if it's anything other than never, that would trigger a flag to go ahead and use the opioid supplement. As I mentioned, like I say, the TCUDS opioid supplement, it is not scored. That's the other thing that we believe is very helpful. This is a very easy instrument to use for first responders. They're getting face-valid questions from the person that they are interviewing or screening. It should be used in conjunction with the DSM-5 diagnostic impression, but for a first look that is fast, easy, and can be accessible to many staff, it does work. Although it may be used as a tool for treatment planning, such as medicated-assisted treatment, as Dr. Peters had mentioned, the ASAM level of care will determine if the treatment approach is the appropriate approach. Again, the opioid supplement is a rapid connection to treatment to help, facilitate that rapid connection, which we know is to be critical, especially where opioids are concerned. So why create an opioid supplement in the first place? Well, as we started out with this webinar, we're in an opioid epidemic. Again, people that have positions and jobs, first responders, especially police, they're overwhelmed and they need solutions and they need them fast. This is helping first responders, especially police, connect with treatment quicker. It does solve the problem and the need for a simpler, faster, and quicker way for a non-clinical staff, including first responders, to identify an opioid addiction population. The first ever screen would be put the focus on the opioid addiction. Again, like I say, this is very specific. The opioid supplement is very specific to the crisis, and the overdose is an appropriate screen for this type of disorder. So those were the primary reasons why we wanted to create something in addition to just a drug screen and have something more focused on the opioid crisis itself. At this time, I'm going to turn this over to Jack Charlier. He's going to take it from here with a few interesting resources that will be helpful to those of you that have joined in on the webinar. So with that, Jack, it's all yours.
Very good. Thank you, Phil, and good afternoon, everybody. Good morning, depending on where you are in the United States. It's a pleasure to be on today's webinar. We're going to start off by talking about one of the main areas of intersect in the criminal justice arena in dealing with our nation's opioid epidemic, and that is from the arena of law enforcement or first responders, and certainly enlarges to fire and EMS through early diversion efforts. So law enforcement, fire, EMS, first responders intersecting with folks who are at high risk of opioid overdose, overdose death, and what does that intersection look like as they interact with behavioral health in a community setting. The two of the resources that you can access in regards to more information about what's being presented are the first two slides, parts of this deck. First one is right here from the police chief article from March 2018, and that goes into some good detail about information that you'll see on the slides. And then the very next one after that comes from the Illinois Criminal Justice Information Authority, and this is more general in terms of a variety of responses available, inclusive of first responders. So the first article from Police Chief really is more for law enforcement. The second one is inclusive of law enforcement and first responders. I co-wrote these with other people who work in the area and who have national expertise in looking at what is a newly emerging field of early diversion, pre-arrest diversion deflection, again, at the intersection of first responders and behavioral health in a community setting in response to the opioid epidemic. So once you look at those materials, you'll get a deeper understanding of the slides we're about to go over. There's not a lot here just because we want to make sure we have time for questions, but this will give you a good general understanding of what we're talking about. So the framework, or the pathway as it's called, and I'll explain that in a second, that matches for law enforcement intersecting with behavioral health in response to the opioid overdose epidemic is called the naloxone plus framework, the naloxone plus pathway. Any of those words work. And we like to say this is designed for saving lives twice. Naloxone plus is the national standard for responding to opioids in the community from a first responder setting. And what we mean by designed for saving lives twice is the use of naloxone saved the life of the person the first time, and then the connection to treatment, the connection to care, detox, outpatient, IOP, residential, whatever it may be, and then into recovery is the saving of the life twice. We know that naloxone might not be sufficient, unfortunately, but the reality is, of course, for anybody who is suffering from addiction, they do need access to medication-assisted treatment if clinically and medically indicated. They do need access to clinical care, and they do need recovery. So naloxone plus framework for first responders is, again, saving a life twice, the first time through the administration of naloxone and the second time through the connection to treatment. I said a second ago that there are pathways or frameworks that help us understand what this newly emerging field of pre-arrest diversion looks like. I'm going to present to you all 5 pathways, but it's really the first one on the slide you're looking at now, the naloxone plus pathway or framework that is going to be the focus of our webinar today. Those articles that I mentioned up front, as well as others that you will find, go into more detail on each one of these. But we're really going to focus on the first one. So when we look at this newly emerging field of pre-arrest diversion, we can describe the 5 ways in which first responders, and in particular, this is really most about law enforcement intersects to behavioral health, and one of those ways is in response to an overdose. That's what the naloxone plus pathway says, is that we are going to respond. There's been an overdose, we respond, and we do the steps, which I'll show you in a second, that go with then connecting the person to treatment. The next one, so that's naloxone plus. Quickly on the other ones, you can read what they say, but I'll just give you an example of it. So where naloxone plus is you overdose, and then first responders get to the scene, do that, and connect you up. Active outreach is where law enforcement initiates contact with folks that they've identified in the community and who are in need of treatment. They usually use a social worker or a counselor. The police don't do this themselves, and there's no penalty, there's no arrest. They're just saying, hey, do you need help? We realize that you might be in need of treatment. If you do, we've got ability to get you into treatment. And if you don't want it, that's fine too, move on. So that's called active outreach. Law enforcement is actively outreaching to folks who are in need of treatment. Self-referrals, where people access treatment by coming into a police station or a fire station and say, I need treatment. So naloxone plus, the person overdoses, that's the topic of today's webinar. First responders engage and connect to treatment, active outreach. Law enforcement is contacting folks proactively and saying, do you need treatment? They might or might not. They might or might not respond. Self-referral, the individual walks into a station, police station or fire station, and says, I need treatment. Again, there's no fear of arrest. There's no, nothing happens if you decline it, and those are 3 of the first 5 ways. The next 2 that you see are about officers on patrol responding to calls for service, or on view, as it's called in the law enforcement world, and they see things. And without going into it, because this is really kind of a different webinar, both of these approaches, these pathways, officer prevention and officer intervention, provide tools through formal policy and training for officers to respond to drug use, mental health, housing, whatever it may be, a variety of services. All the pathways can be used for a variety of connections, including housing and social services. These 2 are more about the officers being on the beat and how do they connect up to treatment. So when you think of the 5 pathways, again, the focus today is naloxone plus, but there are 4 other pathways. And the goal, of course, is for communities to do all 5 pathways. Generally, we find as we look across the nation at pre-arrest diversion and deflection and early diversion efforts, what we see is a jurisdiction starts with one of these pathways, and I'll put the other one back up, starts with one of these pathways, gets experience with it, responds to the problem or challenge that they're dealing with, and then realize and say, oh yeah, we have other ways we can also connect folks to treatment, and we want to build those out. And the main idea here, of course, is that you want to have as much capacity for the residents of that community to access treatment as possible, to access housing as possible, to access mental health, serious mental illness as possible, and all 5 pathways open up that many more ways by which law enforcement and first responders can practice early diversion and hence save lives in the opioid epidemic in their communities. This screen, this slide here shows examples by name. So I just gave you the 5 pathways to the 5 frameworks, but what you see underlined on your screen are what we call the brand names. Some of you will certainly recognize some of these brand names that are on here. You might not have recognized the framework names. Those are kind of the generic categories that we use as we look at jurisdictions across the country and study these and understand what they're doing. These are the brand names. This is like the Wendy's and the McDonald's and the Burger King of the arena of pre-arrest diversion and early diversion. The numbers that you see on there represent the number of sites. So look again at the top of your screen. We're talking about naloxone plus. The main naloxone plus type or brand in the United States is called QRT, Quick Response Team, developed out of the Cincinnati region in Ohio, southern Indiana, northern Kentucky. That's southwestern Ohio, if you're not familiar with the geography. The Cincinnati metro area. That's called Quick Response Teams. The other ones on here are other brands that represent others pathways. And again, jurisdictions start with one and then we'll start doing others. But on naloxone plus, the main one to look at is QRT. This doesn't mean QRT is what you should take and do in your jurisdiction. That means as this newly emerging field has developed, that these are the brands that so far have risen up. But more are on their way. More innovation is coming. To give you a sense of this, in this space right now, or in the law enforcement space side of early diversion, there's about 18,000 police departments in the U.S. We can count about 550, which is about 4%, 550 that are doing some type of early diversion, any of these, early diversion for housing, for opioids, for mental health, in combination. We can count about 550 sites. So the growth is rapid. That growth has all happened in the last 5 years, and most of it in the last 3 years, so that's very fast growth from 0 sites to 550. But still a long way to go in terms of development. So a lot of room for innovation, a lot of room for development of new approaches out there. So I want you to think of, don't pick a brand, don't look at anything on here that's a brand that's underlined and say, I want to do that. Instead, look at the problem you have. In this case, we're talking about opioids, reducing overdose and overdose death, and solve that problem by putting the different pathways together in the combination that works for your jurisdiction based on the resources that you have, the leadership that you have within your police, treatment, community settings, and other factors like your recovery community, your time to treatment. All these pathways and frameworks have different combinations, different recipes, if you will, that are needed to make them go. And you can get more information on that, again, through the resources and, of course, by contacting the Council of State Governments in regards to that. Again, it's the right combination of elements that make up those pathways. It's not about grabbing one of those brands and saying, I want Wendy's or I want McDonald's. It's saying, I want burgers, chicken, and a vegetarian option. How do I get at that? Okay, naloxone plus, that's what this specific webinar is about. Again, this is the main pathway or framework that is being used in the United States right now, and it is considered the national standard for law enforcement responding. And again, this one is one that can be applied to all first responders responding to opioids. So you see on here, and I'm going to show you another slide, so there's 2 slides on this, so hang on. The slides describe for you the different elements that make up naloxone plus. Again, it begins with naloxone, the use of naloxone. You'll see in a second it ends with naloxone. And the different steps are the different elements that make up the entire framework. Now, if you've ever seen me present, you know I don't read slides, and certainly on a webinar, reading slides doesn't make sense. But I am going to read the bold elements, not any of the words, because it's really, really important that if you're going to do a response to opioids, you get each one of these in combination to get to the national standard called naloxone plus. So we already went over naloxone. That's clear. That's where your first responders have access to it. Everybody, as many as possible, have access to it. You need then, of course, a rapid ID mechanism because for someone who's overdosed, time is short, possibly for them to die, and so you need this very rapid mechanism to identify those folks. Contact as quick as possible. You know, this kind of response looks like a response that law enforcement or first responders would do, say, to a fire or a crime scene. That's the speed at which we want to get to that individual. Not because it's a crime scene, not because it's a fire, but because somebody's life is on the line. And again, naloxone plus is about saving a life twice. Then we talk about engagement, and for all of you from the treatment side of things, it is that ability to get to the person quickly while they're in a place that their mind is telling them that they need to do something different, whatever that looks like, and to get to them and build the relationship, the initial steps of the relationship so that you can engage them. Now, let me say for anybody who's dealt with overdose, certainly the first few minutes and hours might not be the place where this happens, but by that person being there and saying, hey, I'm Jack, Phil, I'm here to meet with you, I'm here to help you. Phil says something to me that doesn't sound very nice or friendly, but an hour later I come back and I say the same thing. And then a few hours later, then the next day. In a couple of days, Phil might say, you know, thanks for coming back. I'd like to talk to you about getting into treatment. That's what rapid engagement is. We totally understand that in the opioid space, as in many others, they might not be ready right at that point, but as soon as you can get to them, you should. Then, of course, access to treatment. We know by research that in the behavioral health arena, when someone's ready, you got to have the treatment available because that's when they're ready. It's really that simple. And this is treatment on demand, timed treatment, and what does that look like for your community? Because you need to have that, especially in the naloxone plus space. And the person says, I'm ready, now treatment must be ready. It can't be, okay, next Tuesday at 11 a.m., go to this appointment, and here's a piece of paper. That doesn't work with naloxone plus. That might work with self-referral, maybe, might work with active outreach, maybe, but not in the naloxone plus space. We're really talking about time to treatment measured in minutes and hours. Of course, the next items that you see on here match what Dr. Peters said, what Phil said, what anybody who works in behavioral health or the medical field or lots of service arenas know. You need to then do your screening, your assessment. I'm not going to go into that. That's been covered. Continued tight integration. In naloxone plus, the integration between police and behavioral health, generally not firing EMS as much when they're doing their version of naloxone plus, but police and behavioral health might continue on. I want to caution everybody, this is not justice supervision, this is not justice diversion. It continues on because the police will continue to see Jack on the street and will want to know kind of, am I doing well? Can they provide support to me? Can they help guide me? They're talking to the treatment provider. It's a collaborative support team for continued engagement. It's not like justice diversion where you're doing it for supervision or violation. There is no justice involvement here. There are no charges, right? There are no bail bond. There's no magistrate. Naloxone Plus sits in this newly emerging field of early diversion where people are in the community and there is no justice involvement. Yet, this tight integration is an element of Naloxone Plus that you don't find in all the other pathways, and local communities can build it differently for the purpose of having as many eyes and ears and support and motivational and incentivizing the person continuing in their treatment. Medication-assisted treatment, obviously that's been covered. Understand the importance of that. Recovery support, everybody on this call gets that, and that's really when I said up front that Naloxone Plus really does do the long-run work. Not all the pathways do that. Formally, they do it through the treatment process, but Naloxone Plus does it collectively in a team setting. And it really does do from naloxone to initial engagement to getting into detox or whatever is the correct clinical assessment level or clinical level per assessment that's needed, and then into recovery. And then finally closes out with naloxone, and we want to make sure the person has the ability to have naloxone when they walk out of wherever. And again, this might be something immediate. It might be something that's offered multiple points along the way as they get into regular treatment, OP, IOP, outpatient, intensive outpatient, and certainly in recovery. We want their families and friends to have access to it also. So with that said, I'm going to turn this back over at this point, to Allison, and thank you very much for listening to this part of the presentation and for your time here today. This is super important, the work each of you are doing across the country to save the lives of our fellow residents and citizens and communities, north, south, east, and west. So I just want to say in 5 seconds, thank you for the work you're doing. It means a lot. It's super important. Allison?
Jack, thank you so much. Great content again today, and thank you to you and Phil also for your presentation, portion of the presentation today. So interesting. And so now what we're going to do is use the remainder of the webinar time to take questions, and they're coming fast and furious, which is great. So we have a lot to get to. So I will start. So first of all, I'll just remind the audience that you can chat, use the chat box on the bottom right hand of your screen if you'd like to keep chatting in questions, and we're going to try to get through as many of them as we can now until the end of the webinar time. So the first question, I think, probably Jack could direct to you. We have a member of the audience asking, is there a one-page or other sort of written resource about the Naloxone Plus framework that they can reference?
Yes. So to get more information about Naloxone Plus, the best thing to do, and Allison, this is going to sound like a punt, but it's because I have to get the correct website address, and I don't want to put it out, and my memory is not always too solid. You can go to the Center for Health and Justice.org, centerforhealthandjustice.org, and/or you can send an email to Allison, if that's okay. I hope you get 1,300 emails, and I will make sure that that is the correct email. But centerforhealthandjustice.org. On that website, then, when you get there, you're going to go ahead and see a main landing page, and you got to kind of go a little bit in. But when you do that, then you'll get to an area called pre-arrest diversion approaches, and on there you will see the naloxone plus the full presentation on naloxone plus as well as the other pathways. So Center for, not the number, but FOR, Center for Health and Justice, and it's spelled out, centerforhealthandjustice.org, and then get to pre-arrest diversion, and on there you'll see it. And again, if you have any problems with that, just send an email to Allison. She loves getting lots of emails, and we'll make sure that we get you the sub-link or the sub-URL also. But just play around on that, centerforhealthandjustice.org, pre-arrest diversion, and you will find it.
Great, thank you. We'll be sure. Actually, we're going to chat out the website address for all the audience so they can see it. And yes, we would love to get questions, so please ask. Thank you so much, Jack. And I think this question then probably would go to Phil. It's about the TCU Drug Screen 5. So 2 questions in one, actually. First of all, someone in the audience asked, is there a fee to use the TCU Drug Screen 5 and the supplement? And also, at the same time, they're asking, can these instruments be used with adolescents as well as adults? So Phil?
Yes, the TCU drug screen and the supplement, along with, I believe, all of their interventions and other screening tools are all in the public domain, as Dr. Peters had mentioned, which is why it's so widely popular, because of the fact that TCU does not charge for replication. There is an aspect to the TCU drug screen that involves some computer scanning, but that is not anything that TCU supports. That's actually another software company. But anyway, back to your original question, all of their drug screen tools, all of their tools and interventions are in the public domain. The tools have been normed with adolescents. They are also written at about a 6th grade reading level. And I want to say 90% of all of their instruments are also available in Spanish. They have been translated. So if you go to TCU or IBR, which is the Institute for Behavioral Research, .tcu.edu, and you look at the short forms link, that will take you to all of the screening instruments that they have, both English and Spanish. And if you wanted to look at the interventions, there's a link on that page as well that will take you to things like their evidence-based TCU mapping enhanced counseling, for instance. But yes, everything is in the public domain, which makes it very attractive for those of you who are trying to, implement something at a low-cost level.
Great, thank you so much. Again, very helpful information. Thank you, Phil. And I think these next questions, actually I'll sort of combine 2 different questions into one for Dr. Peters. Some of the audience members are asking a little bit more about the trauma screening instruments. So they're asking, first of all, one audience member asks if anyone is using, or if you know of others using the ACEs questionnaire, so the Adverse Childhood Experiences questionnaire, and also they're asking whether they're asking about the point that you mentioned that trauma is potentially becoming a criminogenic need or dynamic risk predictor. And this audience member says that they have been collecting some information just at their own site on that as well, and they're wondering if you have additional research references you could recommend in that topic area. So Dr. Peters?
Great. Yeah, good questions. So the ACEs is a specialized instrument looking at a history of events that have happened in childhood, and there's some evidence, good evidence over time that those are predictors, of course, of negative outcomes and health-related consequences later in life. That in itself is not necessarily a diagnostic screen it's not a diagnostic screen for post-traumatic stress disorder, but it does give some ability to identify a range of problems that individuals have had that they will carry forward in their lifetime, including sexual trauma, physical abuse, other types of adverse events. And so, boy, that's been used quite a bit in the field. The instruments that I mentioned in this webinar are more those that focus on a history of trauma events, and that would be the parallel, I guess, of the ACEs. But this would look at more of a set of described events by the individual of events that have affected them that have been traumatic in some way, and then connecting those to the level of trauma experienced in terms of symptoms. And so it actually is very useful to combine several of these instruments, such as the trauma history screen or the life stressor checklist, which would get at the same types of things as the ACEs, looking at life events that cause traumatic consequences, and then to combine that with a screen that looks at the actual symptoms of post-traumatic stress disorder that may be attributed to one or more of these traumatic events. And so it's useful first to identify which events have happened, and then to look at the kind of diagnostic impression based on symptoms of post-traumatic stress disorder that may have come from a combination of these events, but in most cases there's one or more sentinel events that have been more important. And so the post-traumatic stress disorder checklist, or PTSD-5, is the one that I mentioned and highlighted. There's also the primary care PTSD screen, PC-PTSD, and a range of other screening instruments that provide a diagnostic impression for post-traumatic stress disorder. And these correspond with the DSM-5 symptoms and give you a score and a cutoff that would allow you to determine if there was enough evidence that someone needed a more full-blown assessment based on the symptoms of trauma. And so I think we'd recommend that you incorporate at least one instrument, if nothing else, something like the PTSD Checklist 5 that would look at symptoms for post-traumatic stress disorder that then would lead to a more full-blown assessment from a trained and licensed clinician for these disorders that would then lead to hopefully involvement in treatment as appropriate. So that's the first question. The second question is about the PTSD as a risk factor for arrest. And it's interesting because I had that down there as the very last item on the dynamic risk factors that potentially contribute to risk for arrest. All the other factors have been pretty well researched and identified and corroborated through research over the years. There's been a single study that I'm aware of, and I'm glad the person is conducting research in this area because we certainly need a lot more data. But the one study that I'm aware of occurred in San Francisco, and it's in the literature, and I can provide a citation for that. I don't have it in front of me, but it was a study that was conducted in the last 3 or 4 years with a sample of several thousand consecutive admissions to the Metropolitan Jail in San Francisco using an offender population and looking at individuals who were diagnosed with mental health disorders, right? So they had typically co-occurring disorders, substance use, mental health disorders. And for that population, it turned out, they followed this population over time and looked at the various different predictors for arrest among that population. And it turned out that post-traumatic stress disorder was an independent contributor above and beyond the other dynamic risk factors that we're familiar with, was an independent risk factor for arrest. So again, this is a population that has a diagnosable mental disorder in which post-traumatic stress disorder was found to be an independent risk factor for arrest in that population. So it may be that, you know, that's just a subpopulation in which we have to provide a little different type of risk assessment that includes PTSD, and that is factored into the risk score that's obtained from a risk screen or risk assessment. But again, we need more data, and I'm really glad that there's some work going on right now from our participants in the webinar.
Great, thank you so much, Dr. Peters. Okay, so some more questions I think that will go back to you, Phil, on the TCU-5. So there's 2 questions again, I'll put in one. First of all, just to clarify, one of the audience members is saying they understand that there is not a cost for use of the TCU-5, but is there they would like to know if there are any authorization costs associated with building the TCU form itself or the questions on the form into their electronic health record. So it's automated, I guess, is what they're asking. Would there be any costs associated with that? And then they're also, another audience member is asking if you could speak to who can administer the TCU. So can non-clinical professionals administer the TCU, for example, parole and probation agents?
Okay, so I'll tackle that first question. Our work with TCU over the last 25 years, they are extremely cooperative when it comes to assisting as much as they can. For those of you who want to maybe automate or include this into some kind of a computerized assessment instrument, I will use our own state corrections department as an example. Our reception and classification centers, with the help of Dr. Knight and his staff, they assisted our IT people, the state's IT people, in developing the questionnaire, and they put it up on the computers so that as inmates are coming through processing, the screen is actually administered as one of the processing stations. Now, with regard to costs for that, I'm not aware that TCU charged anything for their guidance, if you will, but I do know that they did not have a hand in the actual programming. That would be something that's, something you would have to take on yourself. But it's been my experience that any assistance they can give with regard to the proper application of the tools, they're more than willing to do that. Another example I'll use in relation to that, the way the paper document was structured, we asked their permission to move the actual drug questions about which substances you used up to the very front of the screening instrument for the computerized version, and they said yes. The reason for that was the questions were leading up to the actual questions about which drugs have you used, and then, the client would say, well, I haven't used any, that type of thing. So we wanted to put those questions out there first just to gauge where they were at with regard to disclosure. The second part of the question, as I understand it, was the tool. Well, Allison, repeat that second part just so I'm clear on what they were asking.
Sure. So they're asking, can non-clinicians administer the TCU drug screen? So, for example, they give the example of parole and probation officers.
Absolutely, absolutely. Non-clinical staff can administer it. It can also be done in a group setting, which is how we had first implemented it here at TASC many years ago. To give you an example, we were part of a probation program called home confinement. And so every 2 weeks we would have a new class of people that were placed on home confinement for up to a year. And rather than administer the TCUDs individually, we would wait until we had that new round of people, and then we would conduct a class. The reason we did this was twofold. First of all, it was efficient. It was an efficient way of using our staff time. Also, in that class setting, the instructor, if you will, facilitator, could be a probation officer, could be, anyone on your staff, case manager, whoever, actually ask the questions to the entire group, and all they have to do is choose their answer on the form. This got us past the literacy issues, where some people weren't comprehending questions that well, or not reading the questions clearly, that type of thing. So we actually facilitated it as a class where the instructor or probation officer, in our case it was a case manager, who was not a certified counselor but just a case manager, read the questions to the class, they choose the appropriate answer on the form, everybody got finished at the same time.
Great, thank you so much. And I think maybe going back to Dr. Peters for this next question, there's an audience member who is mentioning that from their understanding, that there can be a higher risk of suicidality during opioid withdrawal periods. So they're asking if that's accurate, and if so, what would be screening and assessment protocols around that issue?
Right, yeah, that's a good point. So we have higher rates of co-occurring mental disorders, including depression, of course, and anxiety would be really common components of for individuals who use drugs to start with, but also part of the withdrawal syndrome, of course. So it's a really important point to provide suicide screening, and really that should also be part of the routine screening that you do, not just for mental disorders and post-traumatic stress disorder or trauma, but also for suicide risk. And I think most programs will do that, and that's part and parcel of what we do in everyday work with our offenders and other clients in our substance use treatment programs. But particularly with opioid use disorders, because of the nature of those disorders and the withdrawal syndrome and the fact that people have really gone to great depths and to distance themselves from social supports and are in financial difficulty, have ruined relationships and so forth, I certainly think there's probably a really high risk and probably higher risk than use of other drugs for suicide. And so we do that there's several ways of doing that. A lot of programs have their own kind of homegrown screen that they use for suicide risk. There are common elements, of course, that are asked for examining suicide risk in terms of current thoughts about suicide, any recent behavioral attempts, cutting yourself, taking different types of pills together that might be lethal, other past suicide attempts, of course, having access to firearms, other types of weapons, or other type of access to things that would allow somebody to commit suicide quickly would be something that you'd assess. There are a range of instruments out there that provide a structured approach to that. Columbia University has an instrument. There are quite a few instruments out there that are standardized and have good psychometric properties that have put a lot of these items into a standard format. So I think that's probably the way to go if you're going to provide a routine screening for suicide, which I think is highly important with this population, is to provide a structured screen that then, of course, you would refer people where there's any red flags that come up from that screen. Just as you would with a history of trauma or other major mental disorders, you'd want to have that person seen by a trained clinician for further assessment. And, of course, placement in a secure setting with observation monitoring as a result of that.
Great, Dr. Peters, thank you so much, and thank you to all of our panelists. We have we have many more questions coming in, and we've tried to get through as many as we can, but I do just want to encourage all the audience to see all of our contact information, which is up on the screen right now. We do have several questions that if you contact us directly, we would be happy to follow up with you on. I know we didn't get to everything today. I also just want to say that this is one in a series of webinars that we'll be hosting. And a lot of the questions that were posed really get into more of the realm of treatment and other reentry practices, and also practices for best practices for withdrawal management in correctional facilities. And we're actually going to be hosting webinars in the near future on those topics as well. So look out for those announcements, and we actually plan to keep the questions and cover them during the future webinars as well. But please feel free to reach out to us directly at our email addresses or to me, in particular, Allison Upton. Be happy to follow up with the questions that we didn't get through today. But thank you again to all of our panelists. We appreciate so much your participation today in the training, and thank you to all of our audience. We had great participation today and shows the interest in the topic. So thank you to everyone, and have a wonderful afternoon. Bye-bye.
Thank you.